Hello. This is our second part in discussions of sexual health as part of my human sexual health psychology class. Also was part of my human sexuality class. I'm not taught that online though. In this pretty brief, 4 or 5 lecture series, we'll be talking about sexual health in general. In the previous lecture, we talked about bacterial and viral sexually transmitted infections. I've set aside an entire lecture just to talk about HIV and AIDS, which are, of course, in many ways one and the same, in many ways not. This is a topic certainly of great personal historical interest for myself. I have many friends lost during the AIDS crisis. And in many ways, one of my friends who died is responsible for my being a psychology professor now. So let's dive right into this, and we'll talk a little bit about my own health history as we wander through this topic a little bit. So we're kind of here in the middle of this series of lectures on this topic. So we're going to focus solely on this topic on HIV and AIDS. We'll start with an introduction, which is going to include just a little bit of history about kind of when this virus was identified, and a few sort of points that are of interest. I do want to note that in, I want to say 1983, the prediction was we would have a vaccine for HIV by 1985. And of course, that has yet to happen. So this is a particularly troublesome virus. So we'll start with that introduction, talk about how HIV is spread, and talk about the risk of infection, which is an important conversation to have because it really relates to issues of treatment and testing. Talk about how HIV infection progresses and some of the treatment options. These are ever-changing, so I just want to introduce basically the fact that there are treatment options and they are very good. There are many, many of them, and so we'll talk a bit about that. And then I want to talk about HIV prevention, and then finally a few notes on HIV prevalence and incidence. Let's start with an introduction. The earliest known case of AIDS in the United States turns out occurred in 1968. And so much of what we know about AIDS and HIV is starting to unravel a little bit as we start to understand historically more about how this virus spread. It didn't actually become more widespread or really even noticed, and of course until the late 70s and 1980s. And in June 1981, this is where we see the publication of Morbidity and Mortality Weekly Report from the CDC on an outbreak of rare pneumocystis pneumonia in a cluster of gay men in Los Angeles, along with other rare infections. And because this was picked up by the Associated Press, infectious disease doctors throughout the country discovered that their clusters of pneumocystis were probably related to this phenomenon. In April 1984, so almost fully 5 years later, the National Cancer Institute actually identifies a retrovirus as the cause of AIDS, known as HTLV3. The National Cancer Institute was involved because one of the infections that are associated with advanced AIDS is Kaposi sarcoma, which is a type of skin cancer. And so fully 5 years to identify that this was a retrovirus. And what's important about a retrovirus is a virus is typically a strand of DNA, and a retrovirus is a strand of RNA. And so this is a particularly unique virus in that it's able to essentially become one with the DNA of its host. And so it essentially hijacks your own DNA to make copies of itself. So in 1986, the virus is officially classified as human immunodeficiency virus, or HIV. And this is, of course, what we refer to it as today. HIV is the virus which causes acquired immune deficiency syndrome. And actually, acquired immune deficiency syndrome was the name given to this condition prior to knowing that it was caused by a virus. Essentially, what we know, of course, is that the virus decimates the immune system, and people die from what are called AIDS-related complications. And so, essentially, usually it's pneumocystis or some other secondary infection that normally your immune system would be able to deal with, but because their immune systems are so decimated, that is what causes an individual to finally succumb to this disease. So HIV is spread primarily through sexual contact, needle sharing, or blood transfusions. The risk from blood transfusions is very low because, of course, we now have very good testing methods to make sure that the blood supply is safe. Lots of discussions about the United States being one of the few countries where gay men can are still banned from donating blood, although those restrictions are being eased up during the COVID coronavirus crisis. But there is really very good testing, so there's no reason to continue that ban. So the risk of HIV infection depends on many factors. One of the most important of is whether an infected person is being treated for their infection, or if and what stage they are possibly in their infection. So if they are unaware of their infection, they're not being treated, their risk of passing on the infection is pretty great. If they're treated and their viral load is what we call undetectable, they cannot pass on the virus to another individual. And so we'll talk more about that here in a moment. But the risk of infection from an untreated person varies by activity and sexual activity. So blood transfusion, obviously, the highest risk per 10,000 exposures. Needle sharing during injection drug use or just an overall needle stick. Mid to moderate HIV risk. For people in the healthcare profession, there is a protocol called post-exposure prophylaxis for anyone that has a needle stick, and that prevents them from being infected with the virus following that kind of needle stick. Also often used in sexual assault cases. In sort of regular consensual sex, receptive anal intercourse is the highest risk activity at 138 infections per 10,000 exposures. Again, on average, insertive anal intercourse, that is being the person who is inserting their penis into the anus, is fairly low at 11 per 10,000 exposures. Penile-vaginal intercourse, receptive certainly at twice the risk of insertive. Oral intercourse, very low. Biting, spitting, bodily fluids, other sexual activities, negligible HIV risk. So the biggest risk factors are needle sharing and receptive anal intercourse. And if we just sort of throw this into a just focusing on sexual behavior, it's pretty clear that receptive anal sex is the primary high-risk activity. That allows us then to identify individuals who might be at greater risk of infection and target those individuals for pre-exposure prophylaxis, or PrEP. So HIV progresses in a fairly predictable way, although the time course is different for every person. Following the initial infection, HIV will hijack the immune system to replicate itself. So the virus will multiply inside blood cells, lymph node cells, targeting the CD14 lymphocytes. So these are an important part of the immune system. Most people will have mild to moderate symptoms. They might feel a little bit unwell. They might have a low-grade fever. But in general, it will probably come and go without them really hardly even noticing it. It'll be one of those kind of things. Well, I didn't feel well yesterday, but I feel fine today. Occasionally, people will get very ill. We'll talk about my case in a little bit. I was hospitalized for 11 days following my HIV infection. But I was in this initial infection stage where the virus was running rampant. I had pretty significant symptoms. One of the things that's important in this stage, and again, we'll talk about this here in a moment, is there are no antibodies present in this person, in individuals who are in this stage, and they will test as HIV negative. And what's important about that is this is the stage at which people are the most infectious. So viral load is how we measure the amount of HIV present in an individual's blood who is HIV positive. The goal is to get people under 20 per milliliter of blood. Typical untreated patient in the sort of asymptomatic long-term stage is often at 10,000 copies per milliliter of blood. And I'll show you my lab work here in a little bit. But in this period in which I was hospitalized, my viral load was over 40 million per milliliter of blood, and my antibody tests were coming back negative. And so it's really important to understand that this is the point at which HIV is really, really infectious. So 6 weeks to 6 months later, the body will finally mount a response and start producing antibodies, and we call this seroconversion. This is the point at which individuals will test positive to an antibody test. And most people won't ever do a viral load test unless they've had a positive antibody test. And what's important to understand about HIV testing is they're testing for the antibodies. The sensitivity and ability of those tests depends on what type of test it is. For the mouth swab tests, they're not as accurate as a blood test. Some of those at-home tests certainly are not quite as accurate. So oftentimes false positives can occur. That's the point at which you want to go in and get another test, and probably a viral load test, to see really where you're at. So then we get into this sort of latent asymptomatic phase, which can last for years, 7 to 10 years, at which point viral loads sort of stabilize around 10 to 20,000 copies per milliliter of blood. It really just depends. But it really kind of stabilizes, and then for whatever reason, and we're not really sure what happens, the virus takes off again and really attacks the immune system, and that's when people become symptomatic and will start getting opportunistic infections. So, untreated HIV can develop into AIDS. Usually we consider somebody to have one of the sort of AIDS diagnoses if they have a CD4 count below 200 and the presence of opportunistic infections. And so this diagnostic criteria are changing. I was just looking at the ICD-10 today, and not being a physician, it was not all that clear to me what the diagnostic criteria are, but there are a number of different categories that allow for people to be treated and also to be given pre-exposure prophylaxis with those diagnoses. So fortunately, there are now many treatment options with relatively mild side effects, but this is a lifetime treatment regimen. Once you start on these drugs, you have to stay on them, and they are generally well tolerated, certainly far better than the earlier drugs were. The early antivirals and protease inhibitors were really difficult to tolerate. People didn't tolerate them well. They had to take them 4 times a day. Currently, most people are on a 1 or 2 pill a day regimen, but the drugs are very expensive. So the drug I take is called Genvoya, which I'll talk about here in a moment, is a 4-drug combination that has to be taken every day. The goal here is to maintain an undetectable viral load, as well as to maintain adequate CD4 levels. And what's important is we want to start people on treatment as early as possible. It used to be that people held off on getting treatment until they started going into sort of the next phase, so they came out of the latent phase. But now, because we want people to be, first of all, not passing HIV on to others, but second of all, there is very clear evidence that the immune system recovers much better. There are much lower rates of cardiovascular disease and neurological disease in individuals who have earlier treatment. And so early detection and treatment is very important. So the goal there is to maintain what's called an undetectable viral load. And by undetectable, basically the test detects below the sort of detection threshold for most tests is either 20 to 50 copies per milliliter. Really, below 50 is considered what used to be considered undetectable. Now we consider it less than 20 copies per milliliter. And basically, it's the tests don't detect the presence of HIV. That doesn't mean it's not there. It's just we're not detecting it. And one of the things with viruses is, 1 or 2 copies, your immune system can fight off. But if you are bombarded with a huge number of copies of the virus, your immune system will get overwhelmed. And so the higher someone's viral load is, the greater the infection probability. And we see this with other viruses as well. That is, the amount of exposure is important. So keeping those viral loads low means that we're not going to pass on HIV to somebody else. So an individual with an undetectable viral load is not infectious. They cannot transmit the virus to somebody else. So I do want to take a quick note. One thing on HIV treatment is it is directly tied to access to healthcare, and we're going to talk about that when we talk about incidence here in a minute. But the retail cost of drugs to treat HIV for somebody who has no insurance and no access to any discount programs is about $3,000 a month. I just looked before I did this lecture, and if I went to Costco right now with a prescription, it would cost me $3,200 for 30 Genvoya pills. or $3,200. Most manufacturers can provide assistance. In fact, Gilead has a copay or has a payment and copayment assistance program that has provided me with no-cost medications. So those are possible. So I urge people out there to make sure you're exploring those options if you can. The Ryan White Care Act has established HIV clinics around the country which provide free or low-cost care. And so those are available in most communities. And certainly reach out to your local Planned Parenthood or other county health departments to try to figure out how to get into treatment if you are not in treatment now, because you certainly want to be. And basically everybody that needs care will get care. So this is certainly an issue, and certainly I'm currently uninsured, and it's a barrier to healthcare because getting blood work done and seeing a doctor is oftentimes problematic. So that's something we want to think about. Now it gets us into prevention, and there are essentially 3 categories I've outlined here. Safer sex, perfect use efficacy. When I refer to safer sex, sorry, I should put on here condoms. And so generally when we're talking about HIV prevention, we're talking about condom use, and perfect use efficacy for prevention of HIV is best guessed around 90%. Typical use is close to 80 or 85%, and this is if you've used a condom every time. And the typical use versus perfect use is just simply people aren't that good at using condoms. They break, they aren't put on correctly, they aren't removed correctly, they're reused. Don't ever do that. So you really want to be very cautious that this is your primary mode of prevention. Now, the other option is what's called pre-exposure prophylaxis, or PrEP. And this currently uses primarily the drug Truvada, and Descovy is the other option. This is a 2-drug combination that has a 99.9% efficacy. There are occasionally individuals who are infected with a strain of HIV that is not that is resistant, to these drugs, but it's very rare. And so we're talking about greater than 99% efficacy. And this can be taken every day. And there are programs available. So this is available through Medicare and Medicaid. Everybody is covered entirely by the military. Basically, the goal is in the United States to have everybody have access to this drug if they want it. And again, Gilead, the manufacturer, has some programs available as well. This drug was created by the United States National Institutes of Health along with Gilead. And so if you want access to this drug, you should have access to it. So you can take it every day. It can also be taken using an on-demand protocol, but the thing is you have to know 24 hours in advance of sexual activity. Because what you would do is you would take 2 of these pills, and then 24 hours prior to sexual activity, and then 1 each of the following 24 hours. That can be obviously difficult to predict, and so that's something you want to think about. There's post-exposure prophylaxis, which is a different group of drugs. So it's something certainly to keep in mind. So finally, our final prevention strategy is treatment of prevention, and here's where testing and treatment become important. So what does it mean to be undetectable? Well, undetectable means to be untransmittable. And there are a number of studies that have verified this study I'm talking about here, called the Partner Study. Out of 44,000 condomless sex acts among serodiscordant couples, and a serodiscordant couple is where one person has HIV and the other person doesn't, there were 0 infections. But we have to understand the health risks of being HIV positive are quite real. And so when we talk about treatment as prevention, we're talking about treating individuals who are HIV positive and keeping them from passing on the disease to others. So people who are in treatment, who are well treated, are preventing others from catching HIV from them. And there's also certainly, there are health risks associated with being HIV positive, even well controlled, including chronic inflammation, cardiovascular disease, and potentially neurological disorders. And there's also still a stigma of living with HIV. It's a continual problem. Trust me. It's a problem in the gay community and outside the gay community. And so it's certainly something we have to be mindful of as people. So to give you an idea about how this might work, this is little look at my lab work. Basically, this line is continued in a flat line all the way through my last test. So in October of 2009, when I was admitted to the hospital, I had a viral load above 40 million, which is really the sort of top of this test, above 10 million, sorry, copies per milliliter of blood, massive infection range. Started treatment very quickly, got that down to a little over 1,000 here. I think it was right around 2,000. And it took right at about 6 months to get down to less than 50. And then it was right at a year later, we got undetectable, and I stayed undetectable ever since. The thing to keep in mind is this infectious stage right here, prior to this test, which is actually taken from a bone marrow biopsy, I didn't know anything about an infection, and so I had a highly, highly infectious viral load. So the take-home message here is people who are HIV positive and well-treated are far safer to be sexually involved with than an individual who is not getting tested regularly. And so I think that's the big take-home message there. That gets us to HIV prevalence. At the end of 2016, about 1.2 million adults and adolescents were living with HIV. 162,000 of those, or 14%, had not been diagnosed. Young people ages 13 to 24 are the most likely to be unaware of their infection. 44% of those living with HIV did not know that they were infected. And that's really important that we get those individuals tested, that we target this population for pre-exposure prophylaxis to make sure that we are limiting infections to the greatest extent possible. So one thing I wanted to talk about is HIV incidence. And one of the issues we have in the HIV fight is we are losing the battle in African American and Hispanic Latino males and HIV incidence. We're doing better with white males. Still, all of these could be better, but the Black, African American, and Hispanic Latino communities have much lower access to health care, are far less likely to be getting treated if they have an HIV infection or even being tested for HIV. And certainly the data bears out that these are the least likely populations to be on PrEP, or pre-exposure prophylaxis, that we've been talking about. And it's the most effective way. Treatment as prevention and PrEP are the two most effective ways to reduce the spread of HIV. And so we really need to do better at targeting these communities and trying to get healthcare into these communities, because this is a really significant healthcare issue. All right, that is my quick introduction to HIV and some of its issues. We'll be talking about other sexual health issues in the next lecture.